Okay. All right, so today we're going to talk about the other subcortical motor structure that I mentioned just on Wednesday. And so this lecture is going to follow a similar format, although I've saved the patient videos to the end because I think it's important to understand the structure of the basal ganglia a little bit before you can interpret the kinds of motor disorders that you get from basal ganglia dysfunction. Now, basal ganglia dysfunction is really interesting because it can cause extreme opposites in terms of clinical presentation, and I'm gonna show you that. But so it's the good part will be at the end. In the beginning, though, we're gonna have to go through some anatomy and physiology because the circuit is a little bit complicated. So I'll step through it, and hopefully this will, please raise your hand if it doesn't make sense. Stop me at any time. So like the cerebellum, so last time we talked about the cerebellum, which is here. The basal ganglia, which is buried deep inside the brain, is the other subcortical motor structure that, again, influences movement through its projections to other motor structures. There isn't a direct projection from the basal ganglia down to the alpha motor neurons in the spinal cord. And the basal ganglia is really, it's an important part of the brain, again, for movement control. But when you damage the basal ganglia, you don't become, again, paralyzed necessarily, although you can have trouble initiating movement, and you don't become weak. Just like with cerebellar damage, it influences other things about movement. And in this case, well, I'm going to show you that it sort of helps you to select which movements you want to have come through, which movements you want to make, and which movements you want to suppress. And you'll see that in some of the disorders that I show you. So I'm going to dive right in. This is a coronal slice through the brain. So what you can see here nicely is the internal capsule of the brain. So that's this white band here. And that's carrying the axons from the motor cortex down to the brainstem where they'll cross and go down to innervate motor neurons. So that's the corticospinal tract. It runs in the internal capsule. The gray structures here are a variety of things kind of all smashed together. And so what I'm going to do is I'm going to break them apart for you. Most of the components of the basal ganglia that we're going to discuss today that subserve motor function are actually in this slice, which is why I chose it. And we're going to talk through a little bit about them. We're going to start with two structures, the caudate and the putamen. And unfortunately, in this slice, you can't actually appreciate the three-dimensional structure of the caudate. The caudate nucleus is actually this kind of long, wrapping nucleus. It goes into the plane of the board and comes out of the plane of the board and curves around. So you can go look up a 3D drawing of the caudate. It's actually quite an extensive structure. And the putamen, on the other hand, is sort of a kind of funny rectangular, triangular shaped structure that sits deeper in the brain. Now, I put these two structures together even though they subserve slightly different functions. And the reason that I did is because both of them are input structures to the basal ganglia. So they receive input from the cerebral cortex, and these structures collectively are called the striatum. And so you'll hear the term striatum in reference to basal ganglia, and it's because these two have exactly the same cell types. These two structures are the two structures that receive cerebral input from lots of different places. And so they really are kind of the same structure in a sense, but they do receive inputs from different parts of cerebral cortex. So the caudate gets more information from higher level motor areas and eye movement, areas that are important for eye movement control. Whereas the putamen is all the somatomotor stuff. So that's all the body movement control information is coming into there from the primary motor cortex, SMA, premotor cortex. Okay, this is striatum, this is input. The next structure I'll highlight is the subthalamic nucleus. And you might have heard of this nucleus because this is a target for deep brain stimulation for Parkinson's disease. This is the main target for Parkinson's disease. And I want to talk about that in a little while because after we work through the circuit, we have to think about why stimulation might actually work. So the subthalamic nucleus is sitting right below the thalamus, which is this big blob here. And the subthalamic nucleus also gets a direct cerebral input to it. And it makes up part of the basal ganglia circuit, and I'm going to put that into context in the next slide in a minute. So the next set of structures that I'm going to tell you about is the globus pallidus. Globus pallidus sits right next to the putamen, and it has two parts to it, an internal segment and an external segment. Now, just to make things complicated, you remember that the striatum is really these two distinct nuclei, the caudate and the putamen. The globus pallidus, two segments actually do different things. So the internal segment is an output structure of the basal ganglia, and it's the output structure that's important for controlling body movements. And the external segment is really just a part of the circuit, and I don't think anybody truly understands what its function is, but I'll show you where it sits in the circuit diagram, in the wiring diagram. So globus pallidus sitting next to putamen. The internal segment is an output structure of the basal ganglia, projects out to the thalamus, and the external segment is part of the circuit. Okay. Last but not least, this is probably the part that everybody's heard the most about. This is called the substantia nigra. It's because it has melanin-containing cells in it, so it's dark when you do a dissection of the brain. And there are two pieces of it as well. There's a dark dorsal part called the substantia nigra pars compacta, and that part of the substantia nigra contains the dopamine-producing neurons that degenerate in Parkinson's disease. And then there's a ventral pale portion of the substantia nigra called the pars reticulata. And this part is actually another output structure of the basal ganglia. And it's more important for things like eye control. And all of this should be pretty well written out in my notes, I hope. And you guys have access to my notes. But I just want you to see it in its actual anatomic locations rather than the circuit diagram that I'm going to show you in a minute, because you'll appreciate that, you know, this is spread out through the brain, but it's all deep and they're all interconnected. So one important thing that we're gonna talk about is the fact that the substantia nigra, an important function of those dopamine-producing neurons is to change how the striatum responds to cortical inputs. So that piece of the circuit is actually, as it turns out, quite critical for that, and you get some very specific kinds of motor disorders when you damage it. Okay, now here's the wiring diagram. I think it's easier to think about the basal ganglia in terms of boxes, so that's what I'm doing for you today. So there's a big box at the top, that's cerebral cortex. And I'm gonna think about that as motor cortex because I'm gonna focus mostly on motor dysfunction in the basal ganglia today. So motor cortex projects down, did I turn on all the right mics? Okay, I've got like 50 mics here. Motor cortex projects down the spinal cord and controls movement through the corticospinal tract. We've talked about that a lot. Everything in this wiring diagram that I'm gonna show you is either excitatory in white or inhibitory in blue. And in your notes, I've tried to make those colors distinct as well. So let's start how the cortex talks to the basal ganglia, and the basal ganglia then sort of loops back and talks back to the motor cortex. You can think about these things as sort of a closed loop system. Cortex projects to the basal ganglia, they project back to cortex, and their function is to do something to help cortex with, in this case, movement control. So, as I told you before, the caudate and the putamen are the input structures. So they receive an excitatory drive from motor cortex. And they project directly to the output structures of the basal ganglia, the GPI and the SNPR. So this pathway is you're gonna hear about this as being called the direct pathway. And that's because the input projects directly to the output of the basal ganglia. So caudate putamen project to these two structures, globus pallidus internal segment and substantia nigra pars reticulata. Now, you'll notice that this is an inhibitory projection. So that means that these guys have to be getting excitatory input from someplace else. And I'm going to show you that in just a minute. Now, the caudate putamen, they inhibit this structure, which then actually inhibits the thalamus. So you see that you have this sort of double negative. You have an inhibitory connection inhibiting another inhibitory connection. So what we're going to have to think through in a few minutes is, if you have less inhibition of the caudate putamen connection to the GPI, less inhibition from here to here, you're going to actually end up with more inhibitory output of the basal ganglia. Does that make sense to everybody? Good. Okay, we're going to go through it again and explain how this can lead to disorders. Okay, so this is one loop, and this is the loop through the direct pathway. Now, we have another structure that receives input from the cerebral cortex. This is the subthalamic nucleus. I showed it to you in the last slide, right below the thalamus. And this is the location where people implant invasive brain stimulation, deep brain stimulation electrodes. Some people call the pathway from the cerebral cortex to the STN the hyperdirect pathway, but I don't necessarily, that's not something I need you to know. I do want you to know the direct pathway. But you should know that the subthalamic nucleus receives an input from motor areas in the cerebral cortex. The subthalamic nucleus provides the excitatory drive to the output nucleus. So now here you can see that you have an inhibitory and an excitatory projection to the output of the basal ganglia. And the balance of these things, as it turns out, is very, very important. And when they get when the balance is tipped one direction or the other, you get completely different kinds of motor disorders. So that's I think what's most interesting about the way that this is laid out. Now, in addition to that, there's another pathway through the GPE. Remember I told you the globus pallidus external segment kind of has a different function than the internal segment. And this is called the indirect pathway. And to make it complicated, it has two inhibitory connections as well. So if the caudate and the putamen inhibit the GPE, it inhibits the STN less. And if this is less inhibited, it excites the GPI more. So you can see that this ends up being a little bit of keeping track of signs in order to understand how disrupting any of this circuit is going to affect the output here. Okay? Now, excuse me, last but not least is the substantia nigra, pars compacta. This is where the dopamine producing neurons are. And I've drawn this in a different color because dopamine can have different kinds of effects depending upon the receptors on the neurons that they're targeting. So everything I've drawn before is either an excitatory or an inhibitory neurotransmitter and has those functions. I've drawn the dopamine projection in yellow, and the reason is that this projection, when it impacts neurons that are in the direct pathway, so right here, it actually acts to excite those neurons. But dopamine impacting the neurons in the indirect pathway acts to inhibit them. So dopamine, what it does depends on the receptor in the neuron. Receptors in the direct pathway neurons have D1 receptors in them, and receptors in the indirect pathway have D2 receptors in them. So you have different receptors, so you have different effects of dopamine. Okay, so this is what we have to work with. Yes?
So does that mean it's inhibiting the GPI or the caudate?
So that's a good question. So this projection is to the striatum. So that is to the caudate and putamen, and it affects the neurons that project down. So what it would do, let's just walk through it. When dopamine is released in the striatum, the neurons that lead to the direct pathway get excited. So that means you get more inhibition. Does that make sense to you? And when the neurons that secrete dopamine impact the indirect pathway, they inhibit it. That means you get less inhibition to the GPE. So you can see how keeping track of the signs is a little bit complicated, but if you know all the pieces, you just have to work through it, and it actually leads to some interesting predictions. Okay, is everybody clear on that? I think it's not bad. It's just that you have to keep track of inhibition and excitation. Okay, so I'm going to give you a few slides on physiology, and then we're going to talk about pathology. Does anybody have any questions before we move on? Okay. Now, I'm going to kind of contrast this to the cerebellum. The output of the cerebellum is excitatory, and it occurs before movement starts. The output of the basal ganglia is inhibitory, as I just showed you. So the output from the GPI is inhibitory. And it turns out that that inhibitory activity is a little bit late. So it doesn't always happen before a movement is initiated. It happens maybe simultaneous with it. And so it's not, we think, necessarily completely involved in the planning of a movement. But it does have something to do with the execution of a movement. And I'm going to talk about that in just a minute. There is topography here as well. So in all these nuclei, and I'm not going to go through it because I don't think that you really need to know that level of detail, but there's a body map in there. And so when neurosurgeons go into the subthalamic nucleus, for example, and start recording to try to figure out where they should put the stimulator, they can find receptive fields for arms, for legs in a nicely laid out topographic map. And so what happens, many of you may know, when they're doing this surgery, the patient is awake, and they have them in a stereotaxic frame. Their head is secured into the frame, and they are able to insert very, very thin electrodes, and they record. Usually they record. You could do it just by stereotaxic coordinates, just put it in where you think it should be. But the better way to do this is to actually record neurons while you're implanting the electrode and know if those neurons have receptive fields or not that you would like the neurons to have. And so you want them to have body-related receptive fields. And so this is actually an important thing, is that you have to know that you're in the subthalamic nucleus to begin with, and then you have to find receptive fields. So as I mentioned, and I'm going to explain this even further in a few slides, the activity in these structures is a little bit late, and that's what's sort of diagrammed in the cartoon over here. And so what you can see, if this is a limb movement, each of these ticks is meant to signal activity. It would be an action potential in the neurons in those parts of the brain, or in the muscle it would just simply be EMG or activity in the muscle. And so what happens is that you have muscles coming on before you actually move the limb. That makes sense. You have some time to have the mechanical coupling in the muscle. And then you have activity in some of these structures that occurs a little bit later, kind of right around when the movement is starting. It's not a lot earlier than the movement. And so one hypothesis about the basal ganglia is that it's helping with the selection of what kind of movement you want to make. And I think I'll convince you of that, but you should be skeptical at first. But what people think is that not only when you make a movement do you have to initiate the movement you want, but you also have to suppress the movements that you don't want. And so that this circuit may be important for doing some of those kinds of things. Now, this is really, I think, actually well illustrated in a kind of movement that the basal ganglia really respond well to, and this is a sequence of movements. So if I asked you to make 3 reaching movements to 3 targets, 1, 2, 3, you would have to be terminating the first movement and stopping it, and then starting the second movement, and so forth. Eventually you can chunk it into one sort of more smooth movement. But what happens is that you have to initiate one movement and terminate another movement, sort of close to simultaneously. And so it turns out that if you record neurons in the GPI during sequences of movements, they actually care a lot about sequences. And this is an older study, but I think it illustrates it nicely, because this is one of the phenomenon that you'll see that's important for patients. So patients have trouble making sequences of movements when they have basal ganglia dysfunction, but only in particular situations. So in this study, what they did is they had a monkey trained to do a remembered task, where the monkey had to reach between 3 targets. And the monkey could initiate a go, and there was a reaction time. Here's the end of the first pointing movement, second and third. And so that's what you're seeing there. These are raster plots. So these are plots. Each tick is a neuron's activity, And you're seeing many, many trials of this reaching task. This is where the go signal starts. And down below is a histogram representing the neural activity, so you can see when it's high and when it's low, sort of across many, many trials. And so what you're seeing here is that this neuron, during the task where this animal is actually making these movements, it turns off. Now, what did I tell you about GPI output? It's inhibitory. So by turning this off, it's actually releasing the thalamus from inhibition. So it's actually, in a way, exciting things. But what you'll notice here is that it has this peak at the end where it turns it back on to inhibit something. We think that that something might be part of a sequence of movements. Now, if you look at this down below, it's really kind of nice. You can see that this GPI neuron turns off its inhibition right before you finish movement 3. And so it may be that that's helping you to release that movement to take place during the sequence. Now, the other important thing on this slide that I haven't mentioned yet is that there are 2 other panels, and these are called tracking tasks. So the animals learn to reach to 3 targets in a self-generated way. So the targets didn't turn on, the monkey just had to remember it and do it. But the monkey also had to learn this where the monkey responded to lights on the 3 targets, and so reached when he saw the light to each target sequentially. Now, what do you notice about these same neurons in the tracking task? Well, what you hopefully see is that there's not much modulation. It's not nearly as modulated as it is in the remembered task. And this is an interesting result because this actually suggests that when you're being cued from outside, something's telling you to make a movement, you don't need the basal ganglia maybe as much, or it isn't as responsive. But when you have to sort of internally decide to make a movement, then the basal ganglia become more important. Now, here's the deal. Parkinson's patients, people who have Parkinson's disease and have dysfunction of basal ganglia output, when they have to make self-generated movements, they have a harder time. They have a harder time initiating, the movements are slow. But if you do something like throw a ball at them or put a bright light in front of them, they can initiate movement. The sort of classic thing that I've studied their walking quite a bit, and people will actually freeze during walking with Parkinson's disease. Is everybody familiar with this term freezing of movement? They actually, when they're walking, their steps will get smaller and smaller, and then they'll get stuck. And they'll have trouble initiating a step. And what's so compelling and really works every time is you put something in front of their foot and you say, step over it, and they can immediately start to walk again. So the external cueing helps them dramatically, so much so that they even make like canes that have a little laser pointer in them. And if they get stuck, they push the button and the laser pointer shines a little target on the floor and they can step over it. They actually market these things. So this cueing is actually a real phenomenon. And this physiology is at least consistent with that. It's not necessarily causal, but it's consistent with that idea that you need basal ganglia for being able to select and generate these internally generated movements, but that if you get inputs from other places, it's a little easier for people with this disease. So the other thing that people do sometimes that I think is really interesting is they play marching music for the patients. And you put on marching music and people who freeze or have really slow walking patterns do a lot better. So it's not just visual, it's auditory as well. And one of the therapies that works pretty well for these patients to help them with movement is, get this, tango. They have people with Parkinson's disease. There have been clinical trials now showing that if they are, and these are impaired people, they have a partner who's helping them, helping to guide them, giving them external cues. They have tango music, which of course has a good rhythm to it. They actually move much better, and they really, really, really love it too. So it's pretty interesting that this part of the brain is sort of important for these kinds of things that we very much take for granted, and that it can be sort of subverted by giving input from other modalities. Okay, now, when you lesion the basal ganglia, you can get a couple of different kinds of problems. And I'm going to illustrate two here. This is a study done by John Mink at University of Rochester. And one of the things that he did is he trained monkeys to make a wrist flexion movement. And he had the monkey do this movement in two ways. One way the monkey had to do this movement is loading the flexor muscles. So if you get a force in this direction on your hand, and you want to flex your wrist, by flex I just mean bend it, then if you have a force, you're going to have to counter that force, and you're going to have to use a lot of flexor muscle activity to do that. Does that make sense to everybody? Another way of thinking about it is putting a weight in your hand and pulling up your hand. Okay, now, if I put a weight on the back of your hand, and I had you bend your hand, would you use these muscles? No. Which muscles would you use? The ones on top of your arm, exactly. So you can make a movement. You can make a movement loading the flexor muscles or loading the extensor muscles, which are these. And so the same movement can be made with two different muscle groups. It just depends on which is loaded. So to make it with the flexor muscles, you have to activate those muscles, right? You have to turn on their EMG. To make it with the extensor muscles, what do you have to do? You have to relax the muscle a little bit. You have to turn it off a little bit. Does that make sense to everybody? It's like lowering a book down to the floor versus raising the book. To raise the book, you activate. To lower the book, you relax. But in this case, he's actually flipped the muscles. So that's what he did. And so he had monkeys making these flexion movements. And he did this before and after he inactivated the output of the basal ganglia, the GPI. What you see here is a trace showing the position of the hand flexing. And down below is the velocity. I don't know why it's flipped upside down, but it's not really that sign. Anyhow, in blue is the velocity of the movement after he inactivated the basal ganglia. So what's interesting is that consistently these animals, they were pretty good at turning on that muscle activity during the movement, even when you inactivate the GPI. But if you had to make the movement where you had to relax the muscle, you had to turn it off, then they had trouble. So this suggests that the GPI is important for helping you to inhibit the muscle in order to make the desired movement in this case. So this is just one example of a study showing that really not all movements are the same, and also that there is some specific function of the basal ganglia to inhibit things that gets disordered, and this is just one way it can get disordered after damage. Now I think a really interesting example of this is this classic study that was done by Hikosaka and Wirtz. And in this study, what they did is they inactivated the SNPR, the substantia nigra pars reticulata, which is another output of the basal ganglia. It's one of the two, GPI, SNPR. SNPR controls eye movements. And so what I'm showing you here is a trace of the eye position from a monkey after the SNPR has been inactivated. So after you've shut down basal ganglia output. And what they're asking this animal to do is to hold its fixation on a point. So just to look at a point on a screen. And each tick is a position at a given time of the eye. So what do you see? The eye is not holding steady at all. It's making these unwanted movements, and actually to the contralateral visual field, which is what this is wired up to actually impact. And so again, what you get is unwanted saccadic eye movements when you inactivate the basal ganglia, suggesting the basal ganglia are normally inhibiting movements that you don't want to happen. And so in this case, you want to hold something steady, but you lose this drive, and now things come through. So I think that this is a pretty interesting thing, because you're going to see that I'm going to show you patients where they have problems starting movements and moving slow and stiff, and I'm going to show you patients that can't suppress movements, and they have different lesions in the basal ganglia. Okay. Now, another thing you'll hear about with regards to the basal ganglia is that this is a learning system as well. The dopamine neurons fire at a very low rate, and in this case, I have 2 hertz, which is a ballpark rate for them, so really, really slow. So they can't be signaling anything about the ongoing movement. It's much too slow. And so what we think that is signaling is actually something about an upcoming rewarding behavior. And it's predicting the reward. And it signals when that reward is associated with, for example, another phenomenon, so another stimulus. So let me walk you through this. On the top of this panel where it says no task, this is an old paper by Wolfram Schultz, who has studied this extensively. A monkey is, was this a monkey? Might have been a rodent, I don't remember. Anyhow, animal, shown light, and then eventually gets a reward. And when the reward is given, the dopamine neuron responds. So dopamine, it's like, ooh, I didn't expect this reward, I got this reward, this is great. Eventually, if you keep pairing them, what happens is that in this experiment, he gave them a different trigger. I don't know why it's not the light, but it wasn't. And if you pair them enough, eventually the dopamine neuron starts to respond to the trigger and not the light. So it's anticipating the light. And if you move it even farther forward, you give an instruction that says soon you're going to get a trigger, which is going to give you a reward. The dopamine neurons respond to that. So this kind of phenomenon, they think, is important for changing. Dopamine, we know, changes how sensitive striatal neurons are to their inputs. And the thought is that this is going to help you to form associations and habits of motor learnings, so to speak. The best sort of real-world example, when I think about the kinds of habits that you develop that may be basal ganglia related, I think of things like, have you had the experience, and some of you may or may not have, but when you're like driving a car and you drive to work every day or to wherever you drive every day, and then one day you go someplace else and you start to go to work. Have you had this phenomenon before? It's because you've got this habitual behavior, and that all of the triggers in the environment are consistent with what you normally do, with what your habitual behavior is. Well, it turns out that this kind of dopamine signaling is important for that kind of development of a habit. And that can be good or bad. That can be maladaptive or adaptive. And in some cases, it's very maladaptive. And we think that this circuit then can be problematic if you develop habits that are ingrained in the basal ganglia. Okay, in the last 15 minutes, probably not even that long, I'm going to just show you an example of lesions of the basal ganglia, and I want to walk through where the circuit is going to break down to cause different kinds of dysfunction. So just some basic facts. Basal ganglia function, it functions for contralateral control. So the basal ganglia talk to the motor cortex on the same side. And what that means is that it's going to control the opposite side. So your left basal ganglia will lead to right-sided problems if you lesion it, and vice versa. And that's different than the cerebellum. Remember, the cerebellum has ipsilateral control. So basal ganglia contralateral control, we think that it's important maybe for inhibiting unwanted movements and allowing the movements you want to come through to actually come through. And so it's got this funny inhibition that allows you to do this, or that's one idea. So it may be important for selecting the right motor pattern that you want. And it might be important for switching from one movement to the other. So let me show you, let me describe to you some of the problems you get when you lesion different parts of the basal ganglia. Then we're going to walk through circuits, and I'm going to show you examples of these patients. So you can think about basal ganglia dysfunction as leading to two kinds of problems. Hypokinetic, which you can think of as too little movement or too slow movement, or hyperkinetic, too much movement. And so hypokinetic movements, let's start with hypokinetic movements. These are some terms that are used to describe Parkinson's patients. Bradykinesia means slow movement. Akinesia means no movement, that you can't initiate a movement. Rigidity is a term that describes persistent co-contraction of muscles, making you stiff. Patients with Parkinson's disease also get postural instability, and probably, and I have a great example of this, because they don't select the right muscles to be active in order to resist displacements of their posture. So these are things that you see in Parkinson's disease, and these two in particular are things that I would call hypokinetic. Now, in other diseases that affect the basal ganglia, you can get hyperkinetic disorders, too much movement. So there's something called chorea. Chorea means to dance, and it's an involuntary movement that kind of looks wiggly. It's fast, but not super fast. You see patients with Huntington's disease develop chorea, and these are involuntary movements. So these are movements that you're not trying to make at all. They just come on. Athetosis is a slower form of this. It's a slow writhing movement. There are a lot of kids with cerebral palsy. How many of you have ever seen a child who has cerebral palsy? So these kids sometimes have abnormal muscle tone, and you'll see that they have kind of these writhing movements. That's an athetoid movement, and those are usually the kids that have damage that involves the basal ganglia. Another term that you may not have heard, but I'm going to show you an example of, is something called hemiballismus. Hemiballismus is flinging involuntary movements. So people will actually move their arms really quickly, and it's not voluntary, and it can interfere with their voluntary movements. So the other things you see in Parkinson's disease are dystonia, which are persistent muscle contractions and postures, and tremor at rest. And how that fits into this is not entirely clear, but it certainly is one of the cardinal features of Parkinson's disease. Okay, let's talk about Parkinson's disease. So here's our circuit, and now we're going to walk through the circuit. And is everything okay back there? Oh, not you. It's okay. I just saw them searching for something or looking at the floor. Okay. All right. So Parkinson's disease is caused by loss of dopamine-producing neurons in the substantia nigra pars compacta. So let's walk through what effect that has on the circuit. You remember I told you that actually excites the direct pathway and inhibits the indirect pathway. And so what you see is once you lose those neurons, you lose excitement of the direct pathway. So I've made this arrow get really, really small. Less inhibition. And you get more inhibition on the indirect pathway, which leads to less inhibition here, which leads to more excitation at the SN substantia nigra, the subthalamic nucleus, excuse me. Okay? So you see how the arrows have changed from big to small. I'm just using that to indicate what happens when you lose this drive. And so you have an imbalance between excitation and inhibition at the level of the GPI. And that's going to lead to too much inhibition. So you're going to be inhibiting a lot of stuff. And one hypothesis is that you're inhibiting all the movement that you want to be making. And so it's very hard for them to initiate movement because you're blanket inhibition of movement. So the thalamus no longer excites movement. So I'm going to show you this guy. Wait. There we go. He's not playing in my regular video for some reason, so I thought I'd show you here. This is a guy with Parkinson's disease. Now, before I show you him, I want you to do a couple things for me. I want you to do something like this as fast as you can, just to get an idea of how fast you normally can do this. Yeah, pretty fast. And I want you to do this as fast as you can. Okay, good. And you can stop. And so now let's look at how this guy does those things. Now, there are two things you'll notice. His movements are going to be slower. He's not going to freeze or anything, but his movements will be slower. And you'll notice that his facial expression remains pretty masked. This is another common thing. There's not a lot of spontaneous movement in these patients. They don't spontaneously smile. They don't spontaneously have a lot of gesture in their face or in their hands. So sometimes you feel like they're not listening to you or they're not responding to you because they don't give you the normal cues you expect when you're talking to someone. So you'll kind of notice that with him as well. Okay, so here he goes. Maybe. Here he goes. Okay. So they're asking him just to hold his hands out, spread his hands, and what you're going to see, I don't know why something's bouncing, is he's going to be asked to do some arm movements, like I just told you, as fast as he possibly can. That's not too bad, but it's slower than you guys were for sure. This side, it's a little slow. Now this is him trying to make hand movements as fast as he can, and there you really see it. What often happens is that when they start to make a repeated movement, it damps down, and you see it gets smaller, 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 smaller. And so again, those movements are really slow and stiff. This is bradykinesia. Now he's trying to just open and close his hand like that. And this is all part of a rating scale that they use to clinically evaluate Parkinson's patients. So, and you notice his face just really hasn't changed the whole time. He's just very flat looking. Okay. I think they're going to ask him to tap his hand as big and fast as he can, like this, palm up, palm down. So obviously that's very slow. Okay, so that's one kind of disorder you see. So let me pause it before we go on to our other guy. Yep, sorry I ruined your program. Okay. Hemibolismus, this is the opposite. This is a hyperkinetic motor disorder. This is caused by a lesion of the subthalamic nucleus, usually from stroke. It is a lesion that usually is vascular. It's usually on one side, so that's what, hence the hemibolismus. And when that happens, of course, you lose excitatory drive to the GPI, which means that it's no longer inhibiting movement. So the GPI is no longer inhibiting the thalamus, which then is free to excite the cortex. Yes?
Do you also lose the excitatory pathway to the GPI?
To the what?
GPI.
Oh, yeah, you do. You do. Yeah, this whole thing, gone. But it doesn't have much consequence because it's gone anyhow. Yeah, but that's absolutely right. Okay, so when you do this, you have too little inhibition. And so the hypothesis is that when you have too little inhibition, that a lot of movements that you don't want to make are free to come through, and that you're not inhibiting unwanted movements. You're not selecting the right movements. So let's look at our guy. Whoops, maybe. Here, make it full screen. Now, here's the deal. This guy is being asked to do a neurological exam. He's recovered somewhat from his stroke. And you're going to see him making some movements with his arms and holding his arms out and things like that. But what I want you to watch probably most closely is his leg, because his leg is actually going to start to involuntarily move around. So let's see this guy. Okay, so he's sitting there. And the clinician's going to ask him to move his arm on his right side, is his involved side. So he has damage to his left subthalamic nucleus. And you see how all these involuntary things are going on at the same time when he's trying to move. So he's got this leg movement. He's got tremor on his left side, so he's probably got multiple things going on. But he's not trying to do that at all. That is part of this syndrome. So this is just from damaging another piece of the basal ganglia. And so he tries to move the other arm, and you can see he still has these kind of fast, oscillatory, but not periodic, not perfectly regular movements. Now, I don't know if I include in this video him walking. They're going to look at his foot or his knee or something. Okay. Well, maybe I do have him walking. It's interesting to watch him walk. So you might, what's so interesting about this, from my perspective, aside from it's just really wild and fascinating that you can get such extreme differences, is that when he does walk, his involuntary movements don't throw him that much. It's like nervous system taking into account, even though he's not voluntarily generating them. And so his postural responses are good enough to keep him upright. But you can see he's trying to tap his leg here, and he's just got all these involuntary movements. All right, did you have a question? Yeah. So the interesting thing about hemibilismus is that it subsides some over time. And so there's probably some neural mechanism going on that's rebalancing how much maybe the GPI is actually inhibiting the striatum is inhibiting the GPI. So it does subside some. And then obviously for Parkinson's patients, there are lots of different therapies. There's dopamine replacement therapy, so that you take a dopamine precursor, or you stimulate the STN. And that's sort of the last thing I want to end with, which is why would stimulating the STN help? Because it's kind of counterintuitive. I just told you that lesioning the STN makes more movement take place. And in Parkinson's disease, you're getting too little movement. So why wouldn't you want to lesion the STN instead of stimulate it? Well, it turns out if you do lesion the STN in Parkinson's patients, it does improve their movement. So it helps to balance the circuit. And it turns out that when you stimulate the STN, what you're doing is you're actually blocking its normal pattern of output. And you're replacing it with a regular pattern that has less of an effect or that they think is acting sort of like, it's not really a block, but it's kind of like a lesion in the sense that you're reducing transmission of the unwanted signal through there, which is a lot of excitation. So, so stimulation actually probably works through a mechanism that stops the commands coming through the STN in going to the GPI and replacing it with something else, something regular. Okay, so that is it. These are the two structures that I've talked about. You can compare and contrast them, but I tried to highlight the things that I want you to know for the exam. When is the exam? Monday. Okay. Well, you know, this stuff I'll be asking you probably one question on the cerebellum and one on the basal ganglia. And they'll be short answer questions, correct? Yes. So I think if you just read my handout and read it over a few times, you should be in pretty good shape. I may ask you to identify some things in that circuit or talk about how losing dopamine would change it, for example. Okay.